We have our first speaker, Dr. Anand Kamat.
Thank you, Ganesh. Thank you for inviting me, Varnan, for this excellent NSSA meeting. As spinal surgeons, we like to avoid all complications as they are potentially completely alter the post-operative course of a patient. Sometimes one can get surprised by certain complications and which one did not anticipate. I'm going to present a couple of cases which hopefully will put me in category D of this classification. And if you avoid in your practice, you in category C. This is my case. It was a 45-year-old lady who was admitted with acute psychosis and was referred to me from the peripheral hospital with 5 days history of inability to move legs with bowel and bladder incontinence. They did MRI on day 5 and I was on call consultant and my team was contacted as MRI report stated caudal equina compression. This was the MRI. It did show L3-4 large disc. We got her across. It was difficult to get any story or proper neurological examination as she was in acute psychosis, but I could not see any voluntary movements in her legs. She had ankle clunus, upgoing plantars, and involuntary spasms in the legs. It was also difficult to assess her sensations, but it appeared that she had a sensory level at umbilicus. As she had suddenly lost all voluntary movements in her legs, I suspected a vascular event, probably 5 days prior. I was not happy to go ahead with any lumbar operations, so we asked for a rest of spine MRI, and that was performed. This was that MRI, and it did show a T910 pathology, probably posterior, and causing cord compression and some cord changes at that level. The rest of the spine MRI also showed an upper cervical and upper thoracic cord compressions. Clinically, it looked like it was a T910 pathology. And so I decided that that's the level to be decompressed. The dilemma was, if this patient was paraplegic for 5 days, would any operation be of benefit to her? On top of that, she was in acute psychosis and could not make any decisions for herself. She herself was declining any surgical intervention. We had to take appropriate steps to find out if she had capacity to make decisions. And when it was found that she lacked capacity, we decided in our best interest to go ahead and do the operation. So I did the posterior decompression. I found that she had ossified ligamentum flavum. Good decompression of the thecal sac was performed. She did not improve post-operatively. So this is my routine. If the patient does not improve or I'm not happy with the result, I would normally repeat an MRI to see if the correct level surgery has been performed and adequate decompression has been performed, which was confirmed. Her psychosis improved post-operatively and she regained capacity. And I felt obliged to offer her decompression at the upper thoracic level, which she declined. And she was then sent for rehab to a local rehab center. And as is their protocol, they would repeat an MRI in a reasonable duration of time, which was about 3 months down the line, to see if there is anything new which is happening in the cord. They performed the MRI. However, it was not a complete MRI. She could not tolerate the MRI. And this was the MRI, and they contacted me to give an opinion on this because it did look like at the laminectomy site there was a slip. I got her across, did a CT scan, and it showed this dramatic fracture subluxation of spine. It also showed what contributed to that, which was not evident in the previous MRIs. The spine was completely fused above and below the operated level. If you look at these cuts in the center and on the side, you can see that she has ossified and fused supraspinous and interspinous ligaments all through the spine till L1, L2. She has got bridging osteophytes and OPLL. Facet joints appear fused. And at the level above where I operated, you can see that there is ossified yellow ligament. I took her back to theater, did long fixation and short fusion. And this is a 15 months down CT scan, which shows fusion across the level operated. The second case was my colleague's case, and he's a complex spine surgeon. He asked for an opinion on one of his patients who presented with a septic focus in the body and worsening back pain with neurology in the legs, which suddenly became worse on the day of presentation to us. MRI did show this T7, T8 discitis with epidural abscess. She was brought across to a center and it was out of her. So earlier in the morning, the registrar took her to theater, did a decompressive laminectomy and drained the pus, and it was sent for examination. She started antibiotics and gradually mobilized with physiotherapists. She had almost grazed a bar in the legs, but her sensations were intact, and she started complaining of severe back pain. X-ray of the thoracic spine was performed. It was inconclusive. We did a CT scan, and it showed this collapse and disruption to T7, T8 level, which was the level of the discitis. And the further cuts here show us that she had also got a fused spine, and this was a dish, typical dish type of fusion. She underwent instrumented fusion, and at 6 months, she had good fusion across the infected site. Now, why did this happen in these two cases? Why these cases behave so unusually? Was my decision to adjust decompression wrong? How can I prevent it happening again in the future? Does thoracic laminectomy render the spine unstable? If you look at the thoracic spine, it's probably one of the most stable and stiffest part of the mobile spine. The stiffness of the thoracic spine is because of the orientation of the facets and the bony anatomy of the thoracic motion segment at each level, but also because of the ribs, the sternum anteriorly, the costovertebral and costotransverse ligaments and joints, which render it more stable than the cervical and the lumbar spine. If you look at literature, thoracic laminectomy is a standard operation, which is done for degenerative spinal cord canal narrowing causing myelopathy. For this multicentric meta-analysis does show that the laminectomy was effective even in ossified yellow ligament with good results. It was even used for fused spine, but laminectomy was found to be effective and did not cause any instability. So what happened in these two cases? We know that the thoracic spine has kyphosis. The center of gravity for our thoracic spine is anteriorly situated, and it creates a natural lever arm, which primarily creates an anterior directed compressive force in the thoracic spine. The stress on this particular thoracic spine is increased depending upon the obesity or the body habitus of the patient. Now, this anterior directed force is counterbalanced by the ligamental structures, especially the supraspinous ligament, the ligamentum flavum or the yellow ligament, and the capsules of the facet joints, and to a lesser extent by the interspinous and the PLL, and of course, ably supported by our muscles, the extensor muscles of the spine. This cadaveric study shows that when we do a laminectomy, they took 15 cadavers and they had 7 in which they did laminectomy and 8 were intact. And they loaded them till failure, and it was found that the laminectomy site was the weak point. The failure forces where the laminectomy specimen was significantly lower than the non-laminectomy group. So what were the forces acting on our spine? The anterior-directed thoracic kyphosis and body habitus. Both the patients were quite obese and quite kyphotic. They were counterbalanced by the ligaments, facet joint, and the muscles. And I took out the supraspinous ligament, the ligament of flavum, the interspinous ligament. The facet joint capsule and the PLL were ossified, calcified, and were ineffective as ligaments. And the muscles were paralyzed. On top of that, we know that each segment is able to absorb the mechanical stresses which occur on spine. And the long lever of fused spine created significant pressure on the weak laminectomy site and caused those fractures. So my conclusion in these particular cases was thoracic spine itself is a stable entity and it did not require anything more than laminectomy for most of the cases. However, when there are multiple factors they come together, like paralysis, fused spine, maybe anterior column involvement, maybe sensory loss and motor loss, then we may have to monitor the patients more closely and maybe consider fusion surgery. I would also infer that especially in paralyzed patients where on an emergency we have done a decompressed surgery and before we send them for rehab, it probably is a good idea to do a CT scan to look at the integrity of a mobile segments. It might influence a very close observation to see if they become unstable or may require stabilization surgery. Thank you very, very much. Open for any questions if you have any.
Thank you, Dr. Kamat, for that nice presentation.
Thanks, Ganesh.
If there are no questions,
can I make a comment?
Yes, Madam.
Yeah, thank you, Anand, for that very enlightening presentation, because many times what we feel is what we have done is the most correct thing and we forget about it. But it is also very important to, ask yourself whether you've really done the right things, especially when things go wrong. Okay, when things go right, we take it for granted. And you have shown in your presentation that one has to, as a surgeon, evaluate one's own decision. So, and the role of CT scan, which is very, very important. But are there restrictions in the UK for doing CT scans as compared to MRI? Do you all have any restrictions?
I think most of us, I guess, we do not do CT scan routinely. If you get a patient with cervical canal narrowing, we do MRI. We do not necessarily do a CT scan. If you get a lumbar disc problem, we do a MRI, evaluate it. And there was a canal narrowing there. And in normal circumstances, most of us, we do MRI and base our decisions on MRI. And this is an unusual thing that you got a fused spine. It is not common to see such fused spines. Even in fused spine, maybe doing a laminectomy was all right, and it probably would not have affected it if the patient's sensations and muscle strength was okay, which could have shown us it was becoming unstable. In these particular cases were different. There is no restriction, but ultimately CT scan is a radiation, and we normally do not like to do it unless it's indicated. And I think it would be indicated in these patients to do CT scan before we send them for rehab.
Because in the first scan which you showed, the CT scan later showed a lot of destruction also. If you see, there was some destruction of the body, if I'm not mistaken. So
that's all because of the fracture. There was probably a lot of stress there. The way the spine broke, it will almost look like trauma. So she was paralyzed from there downwards. So she never felt anything. It was a routine MRI. And there was pannus there. So she had broken the spine at some stage and there was bony growth there. Whatever you saw was not fragments, but she herself had started putting bone there.
Okay. Yeah, very nice presentation.
Thanks a lot, Varun, and nice to see you. And thanks for inviting me.
Thank you.